Okay, so we're going to talk about the anatomical relationships in regards to the delivery of local anesthesia and some of the armamentaria that we use in order to do that. Okay, we have an opportunity to use the cadaver as a guide, as a tool tomorrow. Next year you'll get to use your classmates. That's important. I may not want to show up that day, but I think you have to. All right, so, you know, we're delivering this, we need some tools to do this, okay? We need one of these two types of syringes here. We have over on your left, the syringe that we're going to use in the laboratory. This was designed by anesthetic supplier. Primarily, one of the primary local anesthetics was Carbocaine, and this was Cocolate. And you can see it has kind of a, we'll show this also on the overhead, has a round cylinder to put your thumb or whatever finger you feel comfortable with. It has a T-bar to help grip your syringe. It has a neck. It has a plunger in here. We'll look at this on the overhead. It's a little bit easier to see. Here is a plunger, and at the end of this plunger is looks like a little arrow. It's a harpoon that engages the anesthetic carpule, and then we've got this little end down here, which is a screw end, which is to engage the needle. Okay, and there's various needles that we can use. So this is one of the styles that is out there, probably a more popular style because people like the idea of being able to put their thumb in that circle and not lose control of the syringe. The other type of syringe was designed by Astra, which is also a manufacturer of local anesthetics. And Astra has something that's similar except for the handle. The handle is a T-bar, over a T-bar, so to speak. So to basically hold on to those entities as you're doing your injections, you're injecting the local anesthetic. Okay, in order to use these devices, we need something that contains the local anesthetic, and that is this structure here. This is a local anesthetic carpule, and this local anesthetic carpule here is lidocaine or xylocaine 2%. It also contains 1 in 100,000 epinephrine, which is a vasoconstrictor. Now, you don't have to use a vasoconstrictor when you're doing these procedures. Here we have a tendency to use it for a lot of reasons. I think it's more for the instructors than it is for the students, but it is also for the patients because things take so much time here. We would like to see that local anesthetic in that area where we're going to be working there longer, okay? But to be very, very honest with you, once you get into a practice situation, you'll find that some procedures are so quick, and the instrumentation that we use in relationship to doing a tooth preparation is so refined. Okay, so for example, here what I've seen is students use burrs from the time they got them in their 3rd year to the time they left in their 4th year. That's kind of a long time for a carpenter, okay, to be successfully as a cutting instrument. But you'll find that in some cases the tooth preparation is so quick that why anesthetize a patient for 5 hours? But that's something you discuss with the patient. Usually, if there's any type of uncomfortable sensation, it's only for milliseconds. Okay? So we use the anesthetic to get the effect we want. There's also anesthetics that last 8 hours. Okay? I mean, what would you use an 8-hour local anesthetic for? Well, if we've got a procedure that's probably more related to surgical treatment, either multiple tooth extraction or some type of periodontal or endodontic surgery that's involving bone. Okay, you might want to go to a local anesthetic that lasts long. All right, so what's in this carpule? Well, the local anesthetic itself, it could be lidocaine, it could be an entity called carbocaine, it could be an entity called bupivacaine or marcaine. There is a reducing agent in there that has an effect on prolonging the life, along with a preservative, the life of the anesthetic. There's a fungicide in there, so as these things are being stored, that they're not getting any kind of fungal type entity inside the cartridge. And then the ends of it are basically the vehicle for delivering this cartridge. I'll show you that in a couple of minutes. So if we take this, the only other thing we need here is we need a needle. We see the needle engaged on the syringe here. Here we have the different parts of the syringe. Here we have the screw tip to hold the needle. Here we have the plunger and the harpoon that are associated with the anesthetic carpule. And then we have the entities to hold the syringe and deliver the anesthetic. Here we've got the needle on here. It's significant that it's yellow. That actually has a meaning to us. Once again, a 2% lidocaine solution, and here the syringe is loaded. This is what scares the heck out of people. The loaded anesthetic syringe lying on the cartridge is about a foot long. Okay, so a person comes into your operatory. Usually, if you're going to deliver an anesthetic, cover that up before you're going to use it. Okay, so that you don't see, the anxiety starting to come on, or the screaming and saying, I got another appointment I've got to make. Could we reschedule this or something like that? So this is a loaded anesthetic syringe. Okay. All right, so let's look at some of these things, the reality of them. We'll use our skull friend in a minute to look at some aspects of this. But let's take a look at some of these things just on the document can. Maybe. That's got 3 minutes. Okay, so here's a local anesthetic syringe over here. This is a cook weight syringe. Here's the part that engages the needle. Here is this harpoon containing entity in here. Let's see if you can see that a little bit better. Okay, come down on it. And so you see that harpoon, that little point in there, the plunger that is interconnected to the harpoon. You see the hand grasp or the thumb grasp area. Here's another kind of syringe. You might want to buy these if you have a lot of money. This is a disposable syringe here. Okay. It's interesting how they're sold. Okay. It's interesting how they're sold. The little blue thing is, once again, it's a cook weight style. Okay, here the cartridge goes in here. The needle is connected to this housing in here. So how they distribute this is they give you one needle to use for 50 syringe setup. So one of these, they give you 50 of these for every one of these. So don't lose that, okay? It's a very expensive way to deliver the anesthetic. It's a good thing if you're out of an office doing things, let's say in community services and things like that. But basically something to use in a dental office for a period of time is really very not cost effective for you, okay? Anesthetic carpules typically come in a sleeve these days. They used to come in 50 cartridge canisters, but now they come like this. This is what we'll be using in the laboratory. To look at some of the needles here, this cartridge here. Okay, if you'll notice, it has a red housing that is covering the needle. Okay, so this whole thing comes off. This whole thing comes off. But the significance of the red cover is that's the gauge of the needle. Any anesthetic needle anywhere, medicine, dentistry, that has a red cover, any needle that has a red cover is a 25 gauge needle. That's typically the largest needle that we would use as a dentist. Okay, it's a rather large needle. The needles we'll be using primarily in the lab. Here we have this needle here that's encased in its casing. This is yellow here, and this is also a little bit shorter. So these are yellow, anything in a yellow case, that's a 27 gauge needle. That's a little bit thinner. And then if you are so inclined, you can use blue needles, okay? And these are 30 gauge, So 30 gauge is the smallest, so we have 27 gauge. When I got into practice, it got to a point where, I mean, I could use a 27 gauge long needle, which is this one, anywhere. There was nothing that would, you know, for that matter, get in the way of me using that type of a needle. I didn't have to switch between 27 gauge long, 27 gauge short, or 30 gauge short, okay? There's some people that have the belief that the gauge of the needle is directly related to the comfort of delivery of the anesthesia. They will teach you here, or anywhere in any dental school, they will teach you always prior to using a local anesthetic injection, you should use a topical anesthetic over the site where you're going to place that needle, okay? And that's really one of the key things in terms of comfort. If you do that properly, which is really usually with cotton swab, local anesthetic, any flavor your patient likes, you know, I wouldn't particularly keep a lot of different flavors of local anesthetic around. It's not something that most people walk into a pharmacy and get. But use that topical anesthetic probably for a minute over the surface area you're going to inject into, and that will usually allow you enough of an anesthetic to reduce the sensitivity of the needle puncture, okay? The 30 gauge needle, there's this belief that since it's so small, you hardly feel it going into the gingival tissues, okay? I don't know who came up with that. I mean, because everything is relative to the patient, is relative to you. I've told you this once before, I'll tell you over and over again, okay? One person's pain is another person's pleasure, okay? So pain is a very interesting type of sensation. All right, so let's look at some of the ways that we inject. Okay, we've looked at these cartridges. There's one other thing that you might, once again, if you've got a lot of cash on hand when you go into practice, or somebody literally sold you something. That's this. This is a safety needle. So it is enclosed in here, and you don't have to touch the needle when you pull off the cartridge, or pull off the cap. You just go in here and you put your anesthetic carpinal in here, and you take this off, you screw it off, and then from that standpoint, this should come straight down like that. Okay? So when you are not using the syringe, you can put the shield back up. Okay? Those cost 5 times more than a box of regular needles, okay? So that's adding to your cost. I mean, if you develop good techniques, you're not going to specifically stick yourself with a needle. But to be honest with you, that doesn't matter. What does matter is if you stick your assistant, okay? Because you then have to record that. They have to go through a screening to make sure that they don't get hepatitis. You have to keep that record for 10 years. Okay? So you don't want to stick your assistant with a needle, but you can stick yourself. So whatever you're up to. All right, so let's look at this. Basically, what are we trying to do? We're trying to anesthetize branches of the trigeminal nerve. Let me get back over here to the laptop. Maybe. Yeah, that's Okay, so we're trying to anesthetize branches of the trigeminal nerve. Why? Because it's branches of the trigeminal nerve that innervate the dentition, okay? And typically that's our role, is to do basically dental surgical procedures on the dentition, or on the gingival surfaces, or on possibly on bone associated with periodontally involved surfaces. So here we see the full scope of the trigeminal nerve, looking at its highest components, ophthalmic division. Probably we're not going to get involved too much with ophthalmic type division injections because they are not involving teeth, although some of them do involve, in particular things, areas like the frontal sinus, so some type of craniofacial surgery. Maxillary division has this branch that comes out of the pterygopalatine fossa and leaves the pterygopalatine fossa through this pterygomaxillary fissure and then goes into openings in the maxillary tuberosity, referred to as the posterior superior alveolar foramen. But it also leaves in here, leaves the infraorbital branch and travels through the sinuses to the anterior maxillary dentition, the dentition to the premolars, the dentition associated with the first molars, first premolar, second premolar area, possibly even the canine tooth. And then we have a portion of that branch that goes to the anterior excuse me, the anterior dentition of the maxilla. Okay, so these are sometimes called middle superior alveolar and anterior superior alveolar. The mandibular division, the third division, gives rise to the innervation of all the lower teeth, from the anterior most central incisor all the way back to the posterior most molar, which is typically the third molar if it's present. So those two divisions, the anterior inferior, middle inferior, and posterior superior alveolar, are associated with the maxillary division, and the mandibular division gives rise to the inferior alveolar. Okay. So here we see some of those maxillary branches. Here we see the branches back here. Here is posterior superior alveolar branches that are coming out here. Some of these are coming out to the gingiva, but there is a branch that goes through bone and innervates third molar, second molar, and at least up to the buccal cusp of the first molar. If there is a middle superior alveolar traveling through the maxillary sinus, it typically may innervate the two premolars, but it also may innervate the buccal cusp of the first molar. And then we have the anterior dentition, the canine, the lateral, and the central. Those are pretty much being innervated by the anterior superior alveolar. Now, anterior and middle typically come off of infraorbital. Posterior superior alveolar actually is a separate branch that travels out of the pterygopalatine fossa to innervate the molar dentition, coming in through posterior superior alveolar foramen. Then on the inside of this dentition, there is innervation primarily of the gingival tissues, the mucosal tissues here, that are coming through the greater palatine foramen primarily and innervating the attached gingival surface on the palatine surface of the maxillary dentition. Okay, so there's also a branch up front here coming through this opening. Right there, okay? That's the incisive foramen. And that is sometimes also called the nasopalatine foramen or canal. It's a bilateral canal, and those are the nasopalatine branches of the maxillary division, okay? So these are coming through openings that we should already be familiar with. Now, when we're doing maxillary anesthesia, we are typically coming up under the gingival surface. Here, we see an injection. This looks like it's a 27, could be a 27 gauge long or short here, but we're injecting. Let me change the color. Okay, so we're coming up. Here's the frenum over here. So there's a difference in maxillary bone versus mandibular bone in relationship to its thickness. Maxillary bone is more cancellous, it's more porous. So local anesthetics over a period of time, probably of 5 minutes, possibly 10 minutes, but within 10 minutes, you should be able to get the fusion of that local anesthetic to the apex of the tooth you're trying to anesthetize, okay? You bring that injection in from the labial, okay? So here, this is a maxillary anterior dentition. This is anterior superior alveolar branches. You can see that the operator has injected essentially a half a carpule into that area, over that area about the length of the root. What's the length of a maxillary central incisor root? 10 millimeters, 12 millimeters maybe? Okay, so we already know that that gingival attachment, that mucogingival junction, is probably only at most about 5 millimeters above the dental enamel, the cervical aspect of the tooth, of the maxillary tooth. Okay, so we have to go another 5 millimeters above. Okay, now can we go higher? Yeah, we can go higher. But that's not what we're trying to do. And if you keep that needle against the maxillary bone, that little lip of bone coming over this area in the nasal area, I'll show you that over here. Hopefully I can get back to the Okay, so if we look at this area over here, here's maxillary dentition, not in very great shape, but as we bring the syringe up, if we keep it against bone, we're going to lodge in this bony area here, just at the floor of the nasal cavity. If we're out too far anterior, when we pull on the lip, we're going to be on the outside of this nasal opening, and we're going to inject into the nasal vestibule, okay? So you may get some nasal vestibular anesthesia, but you won't get any dental anesthesia, okay? So we see these two openings here. Let's use our anesthetic syringe kind of as a pointer. Here is our nasal palatine canal here, going in here. Here's our greater palatine canal back here, okay? Just behind it is the lesser palatine canal, and this one is kind of closed down because it's been coated with some type of sealer, so we don't have much of one, but we do have this greater palatine canal here. Okay, so the one thing I'll tell you when you're doing local anesthetic injections, or you're doing any kind of anesthetic injection, bone is your friend. Bone keeps you from going where you don't want to be. So if we inject and we wind up engaging the bone over the central incisor here, and we bring the needle down, that's pretty much as high as we can go. Okay? If the needle is out here, then we're not going to inject where we need to inject. Get the dentition. We're just going to wind up injecting a bolus of anesthetic. These are about 2 ml cartridges on average. We're going to inject 1 ml of local anesthetic into the nasal vestibule. So we inject that local anesthetic in here. You can see that the bone is very cancellous. or spongy. And that's going to filter in around the apex of the tube, so we're going to anesthetize that too. So we don't necessarily have to get a broad anesthetic. The more localized that you use the anesthetic, the better it is, not for you, but it's better it is for the patient, okay? You just need to use the anesthetic quantity that you need to do the procedure that you're going to do, okay? Block anesthesia, you'll see, causes a lot more of an issue in terms of the distribution. So here, for example, we're out over premolar. In this area, a little bit farther lateral over the premolar. So if we go in here in relationship to that spot, we are essentially trying to keep the needle, once again, under the gingiva, but into an area where bone is going to basically help us limit the passage of the needle. So, for example, here's a canine. This is the canine fossa up here. So, if we go up high, what's going to happen is the zygoma over here is going to stop us from going higher. The same thing with the first premolar over here. First premolar over here, so this is about all we need to go. Second premolar over here, you see the zygoma over here. If we're trying to get back around the molar, it's going to be tough to get around the molar because of the zygoma. We'll talk about how we're going to get back there. So depending upon where we want that anesthetic to be, is going to depend upon what our approach to the tube is. Yes?
How much of the needle do we put into the gingiva? How far are we going?
For maxillary dentition, probably only in a 27 gauge long needle, half the needle.
Half the needle?
Okay, depending upon a canine tooth, because a canine tooth could have a root that's 15 millimeters long. Okay, so you may have to go the full length of the needle in order to get that anesthetic deposited on the surface of this cancellous bone above the apex of that root. Once again, they're showing 1/2 of a carpal, okay, injection. Okay. Local anesthetic by itself in a cartridge will give you about 2 hours of soft tissue anesthesia. Okay. If you add a vasoconstrictor to that cartridge, it'll probably at least double the amount of time that local anesthetic will be there, or possibly it could be, instead of two hours or 4 hours, it could be 5 hours of local anesthetic, because the vasoconstrictor reduces the vasculature in terms of its diameter and reduces the absorption of that local anesthetic will be broken down in blood. So molars are a little bit of an issue because we have to get that local anesthetic kind of past the zygoma. Here's our zygoma here. Here's our zygoma over here. Okay? And this is a cut through the maxillary sinus over here. So we're trying to inject around here, or around here. So when we bring the anesthetic syringe in this direction, we may bump into the zygoma right here. You'll be able to see that and feel that in the laboratory. So we want to, let's say, get a molar anesthetic, okay? You should be able to get a half a carpule, 3/4 of a carpule into this area with a 70 gauge long needle, or 25 gauge needle if you so desire, to bring that needle above the root apex of a molar. Obviously this one is above the third molar over here. So angling, in this case, what the operator did is they injected a little bit farther back, okay? So how would we do that, okay? How would we do that? We would do that by coming in here. We're coming from an anterior direction, okay? If we come in too quickly, okay? Here, we might not get further back than the first molar. If we inject here along the alveolar ridge, we have a better opportunity to inject a bolus of anesthetic here. If you notice, the bone gets thicker. So what you might want to do is, instead of injecting a half a carpule, you might want to inject a full carpule of anesthetic here when you're trying to get enough anesthetic to go through the bone. Okay? So we're bringing it in at an angle. If we want to get back to the third molar, the second molar, if we keep it a long bone here, we're going to get trapped by the lower portion of the zygoma as it's meeting the maxillary alveolar process. So we want to keep it down here and kind of from the apex, or I should say the cusp tip of the cuspid, is to bring it a long bone, bring it down the bone, bring it a long bone, and then inject back here for a second molar, or way back here for a third molar. Okay. So the bone is going to give us an idea of where that needle is. We're using the bone to slide that needle back onto the area we want to deposit the anesthetic. Here we see, going way back here, here's a lateral, here's a canine, here's the premolars over here. So this is actually going back probably the second molar area back here. We're trying to bring the needle underneath the zygoma, but also alongside of the dental bone of the maxilla in order to use that as a guide for that injection. Now on the other side here, we've got palatal nerves, greater palatine nerves to the palatal gingival mucosa relationship. We've got lesser palatine to the soft palate, unless you're doing a palatopharyngoplasty, which I doubt if you would do that as a general dentist in your office. But if you are going to inject into the hard palate, you're going to use an approach like this. And in this case, if you notice in the cadaver, if you haven't so far, I noticed that some of you were in here over break, that the palatal gingival mucosal region is very, very tight over bone. It's very tight over the maxillary processes and the palatine processes that are forming the hard palate. So when you go through there and you inject just a little bit of fluid, it stretches those tissues. And as it stretches those tissues, it pulls on the nerves. So that will actually create a situation where you should probably, just like any place else, use a topical anesthetic prior to using an injection site. Try and get your injection a little bit farther back in relationship to the nerves that you're trying to anesthetize. Here's the central incisor over here. Okay, here's the canine, here are the two premolars. So they're trying to inject just behind the canine tooth. Okay, what is that for? Well, to be honest with you, they're not going to get dental anesthesia. You're not going to get dental anesthesia by injecting on the palatal side. Okay, sometimes you do it if you've done a molar injection or you've done a premolar injection from the buccal, and you're not getting profound anesthesia. You may try to get a greater anesthetic effect by injecting on the palatal side, but sometimes that just doesn't work well. The anesthetic will diffuse to the root apices of premolars relatively easily, canine tooth relatively easily. The palatal root of the maxillary molars not as easily. Okay, but if you give it time, you will get anesthetic if it's around the apex area of the molar roots. Okay. Doing a palatal injection, unless you're doing something associated with doing some type of tooth preparation close to the cervical neck of a molar tooth, okay, really isn't necessary. Okay, if you're doing for example, a class 2 restoration. However, they're teaching you, and you're using restorative material now, you're doing restorations, right, in the lab. So I'm assuming they give you some type of a device to hold that material on the mesial or on the distal surface of the tooth where it's in contact with the adjacent tooth. Have you done that? Have you done any class 2s? Okay, so as that matrix band comes around the tooth, to hold the material in the right place, it's going completely around the tooth, so it may dig in to the palatal gingiva, okay? So you may want the anesthetic there just to help the patient with, preventing discomfort of that band coming around the tooth, okay, as well. There's another, the older retainers are called Toffelmeyers. Toffelmeyer, who invented that, was actually a Navy captain, okay, out on the West Coast, okay. Just from that little thing, he made enough money to retire for life. Because, Toffelmeyer retainers have been done for the last 100 years, okay. To hold the matrix, you might want a little extra anesthetic on the palatal surface. Yes?
How far can you stick the needle into the palate? Like how
You
far
can't stick it past the bone in this case.
Yeah, so it's only gonna be like the tip of the needle?
That's what, yeah, and this is, what they're showing here is they're using basically maybe 10% of the cartridge, okay, to inject it. Because that's enough, because the tissue is so tight, it's gonna kind of contain that anesthetic in that area where you're placing it. Okay, now sometimes we want to get a more profound effect. So for example, what if we wanted to take out all of the dentition in the maxillary left or the maxillary right? Okay, we got some choices here. The choices they will probably make for you here is you will take a needle and turn the patient into somewhat of a dental pincushion and just keep injecting cartridges until you've injected enough anesthetic around the palatal and the buccal and labial surfaces of all the dentition. There's an easier way to do that, but I doubt if they will let you do it here because they've probably never done it in their office. All right? And that is to anesthetize all of these teeth with a single injection site. And we can do that by actually going in here into the greater palatine foramen. And injecting up to here. What's this area that I've circled? Where that little bulge is? Pterygopalatine fossa. Okay. So what are these fibers coming down here called? Or going up actually? Descending palatine fibers. And they're coming out of this opening here, which are the greater palatine foramen and the lesser palatine foramen. So if we inject here and we take the needle and literally with a long needle, literally bury it in that opening, we can inject a bolus of anesthetic into the pterygopalatine fossa. Now there's pluses and minuses. The pluses here is that we can anesthetize every branch of the maxillary division with a single injection site. Every branch. So all of the palatine fibers, all of the buccal fibers going to molar dentition, all of the buccal fibers going to premolar dentition, all of the all of the anterior dentition, canine to central incisor, can be anesthetized with a single injection site. And also you would get the nasal palatine branches. So this is called a division 2 block because that's what we are successfully blocking. We are blocking the second division of the maxillary nerve. So For if we go over here and look at where we would inject on this skull, we would go into this area here. Here's a greater palatine foramen. Now typically what you first have to do is you have to inject a little bit of anesthetic in here because you may have to feel for the opening. Okay? You may have to feel for the opening. But once you get into it, and we'll show you this in the lab, and you can try this in the lab, the needle will go all the way up to the pterygopalatine fossa. So you will be able to inject a full bolus of anesthetic into the pterygopalatine fossa for a division 2 block and block the entire maxillary division on one side. Yes.
Okay, so a question about the actual injection part. Do you inject once the needle's all the way in? Is it gradual? Is it pulling out?
Well, one of the things we'll look at in a minute, we'll look at tomorrow, is that all of these syringes that I showed you are referred to as aspirating syringes. So the reason the harpoon is there is to engage the cork on the anesthetic syringe, and as you push or pull, that is going to either push out local anesthetic if you push, or pull back the local anesthetic or whatever is at the tip of that needle, okay? And the dentistry is probably the only clinical profession that uses aspirating needles or aspirating syringes. So the reason for that is that there were incidences, obviously, that happened where somebody injected into a blood vessel. Okay? We'll talk about this tomorrow when we're doing the exercise. But you don't want to inject this anesthetic into a blood vessel, do we? Why? What's in these cartridges? You haven't had anything about local anesthesia yet, I'm assuming, right? Because that's, I think, one of Dr. Qureshi's instructions, okay, in oral surgery. Do you know what the effect of a straight local anesthetic is on the vasculature? No vasoconstrictor, just a local anesthetic. What kind of an effect does it have on a blood vessel? It's a dilator, okay? All local anesthetics except one are vasodilators. Which is the one that's not? Cocaine. Cocaine's a local anesthetic, was typically used a lot for ophthalmic procedures, okay, in, for example, lens replacement and things, or corneal surgeries. It is the only vasoconstricting local anesthetic. All other local anesthetics are dilators. So that's why they came up with the idea of putting a vasoconstrictor in there, especially for dental students who the procedures take twice as long or longer, to keep the local anesthetic in that area longer. So we're typically using epinephrine or adrenaline usually from the standpoint of about 2%, okay? Or I should say 1 in 50,000, 2% local anesthetic with 1 in 50,000 and 1 in 100,000 concentration of epinephrine. Okay, so that's going to keep the anesthetic there longer. But the local anesthetic itself is a vasodilator. So if you're doing a surgery procedure, the problem you have is that's going to facilitate bleeding from the blood vessels that you're going through in your surgery. The anesthetic isn't going to last as long, but that's not necessarily a bad thing, okay? Like I say, how long do you think it would take you to do a little occlusal composite restoration with a sharp carbide burr on the occlusal surface of a premolar? How long should that take you to do the preparation?
Should take 5 minutes.
Huh? How about 2? How about 2? So are you going to give them 2? Think about this from the patient's perspective. Do they want to be anesthetized for 2 hours? Okay. Now, the thing I would tell you about dental patients is all they have to see on the outside of the door is DES or DMD, and they're frightened before they come into the hour. So the fear of pain is the typical thing that patients that are coming to see you as a dental practitioner is what the issue with the patient has with you, okay? If you can demonstrate to them your expertise in controlling that pain through the use of local anesthetics, through the use of other types of, let's say even biofeedback type mechanisms or things like that, then you can usually do these procedures. I mean, you can probably do easily four restorations in a sextant in probably 10 minutes most. Okay, that's with a good assistant. All right, and the patients like that. They don't want to be there all day. They've got no desire to be there all day. Okay, the sooner you get them in and out, they're going to appreciate that. The less pain that you cause them, they're going to appreciate that. But in order for you to think about that, you have to know what the armamentarium that you're using does, especially what anesthetics last longer, what anesthetics are shorter, what anesthetics contain vasoconstrictors, what anesthetics do not. Usually anesthetics that last longer, okay, have a tendency to also have an effect over a longer period or have an effect not only over a longer period of time, but it takes them a longer period of time to have an anesthetic effect. Anesthetics that are shorter, typically the anesthetic effect comes in much more quickly. Okay, so we can use this Division II block, okay, like I say, unless, when you do your surgery rotation, you may see this used with some of the oral surgery residents, or you may see it used in a surgical situation. It is actually a good local anesthetic approach. What's the problem for it, okay? What do you do in maxillary arch? How is the patient seated? How are they positioned in the chair? Supine, right? Okay, so if you're injecting up towards this fossa, what is in front of this fossa? If the anesthetic is kind of sitting there for a long period of time, what's in front of this fossa? What region? The orbit. Okay, the floor of the orbit. If the anesthetic gets in there, it may have an effect on one or more of the extraocular muscles which attach in the back of the orbit. And then you've got a problem because as long as there's an anesthetic effect of those muscles, the patient is going to be diplopic. On the side where the anesthetic affected the muscles, those muscles are not going to be in sync with the muscles on the opposite side where no local anesthetic was used. So how do you have to handle that? Well, how I would have handled it in my practice, if I knew I even thought I was going to use that, the patient had to come in with someone, they're not driving in alone, okay? Or they're not driving home alone, okay? If you're in a situation and they come in there, you've got two choices. You can reschedule a procedure, or the only really other choice that you may have is have a box full of pirate patches in a drawer and put that patch over the affected eye so that they can see. But still, you're setting up risk for the patient if they're driving an automobile, okay, or riding a bike or something like that. So if you're thinking of doing a Division II block, you have to think prior to that, what is the purpose that this patient is coming into you for at this given point in time? What's the anesthetic effect that you want to deliver there, and for what reason? Okay. Like I say, you don't necessarily have to have a local anesthetic to do a small occlusal restoration. Okay, that should be done in probably from the time you get the patient in the chair to the time you pick up your handpiece. It should take from start to finish no more than 5 minutes, probably less, for a single. Okay, so here we've seen this before. Here is these are the descending palatine nerves coming up. There's the, what's this? What's that structure? Vertebropalatine ganglion. What's this structure here? That's the maxillary nerve. Coming through foramen rotundum, and we don't kind of see, there's a tiny little hint of the greater petrosal nerve coming in here, okay? So this would be greater petrosal. This would be B sub 2. This would be pterygopalatine ganglion. Now, I mean, the reason why this Division 2 block is so significant is, okay, here's the other choice. You're going to take out all of these teeth. So you're going to need local anesthetic not only on the buccal but on the palatal, right? Okay. Let's change the situation. You're going to do a periodontal flap, a buccal flap. Down, pull that mucosal area up from the neck of the tooth, okay? Or you're going to do an endodontic surgery on the apex of a tooth, and you're going to pull that flap of tissue up, okay? So you loaded all this anesthetic below the tissue against bone. Now you're going to do your flap, and what's going to happen to the anesthetic? It's going to fall out into their mouth. It's going to flow into their mouth. So you're going to probably have to do several injections in order to have a profound local anesthetic effect. So that's why this Division 2 block is rather helpful. All right, let's move down below. Tell you what, take a 5-minute break and then we'll move down to anatomy. The trigeminal nerve. And what you see is all of the main branches and their sub-branches that are associated with the mandibular innervation, okay? We don't see inside the mandible, so once the mandibular division has gone inside of the mandible, it is the inferior alveolar nerve. So this is the mandibular foramen, or inferior alveolar foramen. And once this branch here goes in there, it is going to innervate the dentition. So this is the inferior alveolar nerve, okay? Now I'll ask you a question. What type of nerve components are in the mandibular division of the trigeminal nerve as it first enters into the infratemporal fossa? As it goes through the foramen valley and enters the infratemporal fossa, what type of nerve components does it contain?
SVA.
SVA. Where do those come from? So it just is going through foramen valley. Hasn't gone any farther to pick up the chorda tympani. Okay? It itself has a cranial nerve division 3 of the trigeminal. Okay? So trigeminal does not itself, as a cranial nerve, have SVA components, that special sensation for taste or smell. So what components does it have? GSA, SVE, okay, what else? GVE, good. Where are those GVE fibers going? In this case, we haven't gotten the chorda tympanic branch, okay? So those upper fibers are part of the great auricular nerve, the auriculotemporal nerve, which is going to skid on the outside of your temporalis muscle, but also the upper aspect of your earlobe, But also, what structure is out here? What structure is out here in front of your ear? The parotid gland. The parotid gland. And that is primarily innervated by which cranial nerve? 9, the glossopharyngeal. So there is a ganglion in the foramen ovale called the otic ganglion, which receives preganglionic parasympathetic fibers from a branch of the glossopharyngeal nerve called the lesser petrosal. They go and synapse in the otic ganglion, and then the postganglionic fibers drop off into the auriculotemporal branch of the mandibular division and are carried to the parotid gland. Now, once we pass the foramen ovale, we pick up this other autonomic branch from the facial nerve coming through the petrotympanic fissure. What's that branch, Brian?
That would be mandibular.
Okay, joining the mandibular lingual portion, lingual branch, is a branch of the facial nerve that has exited the middle ear chamber, and that is the chordotympanic branch of the facial. Now, this lingual portion of the mandibular division contains what kind of components? What does that nerve trunk contain?
Are we still on 5 or 7?
So we're on cranial nerve 5. Okay. So now it also has what is the primary role of trigeminal? Primary role of trigeminal is sensory. Okay, in all 3 of its divisions. Okay, so it's got general sensory coming from the tongue or the lingual mucosa. Okay, but what's it carrying in relationship to the facial nerve now? It's carrying those chordotympanic branches, which are what type of components? SVA coming back from the anterior 2/3 of the tongue, and what else? GVE going to the submandibular gland and the sublingual gland. Okay. Yes?
So as it exits the mandibular foramen, you said it had 3 components, GVE, and the GVE is from the,
As it exits a foramen ovale.
okay.
Okay? It has GSA, it has SVE, and it has GVE. Okay? But now we're down maybe about a half an inch from the foramen ovale, and we've picked up these fibers coming out of the petrotympanic fissure, specifically joining the lingual branch. Those are the chordotympanic branches of the facial nerve that left the middle ear chamber through the petrotympanic fissure and joined the lingual branch of the mandibular division. Okay. So now that lingual nerve trunk carries SVA from the chordotympany, GVE from the chordotympany, but as a trigeminal entity it carries just GSA. Okay. Okay, now over here there is a branch that before the mandibular, the inferior alveolar here enters the mandibular foramen, it gives off this branch here that comes down into the floor of the mouth, okay? You see a lot of sub-branches here, okay, coming off here. And it runs along this groove here, okay? And it actually creates a groove on the inside of the mandible below a ridge. What's the ridge called? Mylohyoid line, or the internal oblique ridge, okay? And what's that indentation? You can see that, I think we can probably see that here. Yeah, maybe. You get the right light. Oh, can you do it later? Oh, I don't know. So we see this line, I think, let's see. You see that? Here's mandibular foramen, there's the lingula, there's the mandibular foramen. Here we have this groove here that's gonna run under this ridge, that's the mylohyoid line over here. And here this groove is for this nerve branch of the inferior alveolar called the mylohyoid. What kind of nerve components are in there? Mylohyoid branch. What kind of nerve components are in there? Well, GSA, right? To this area in the floor of the mouth. Okay. To the skin underneath the mandible in relationship to the skin in the mental region. Okay, the chin. Okay. What else? What other nerve component is in there? SVE, motor to the mylohyoid muscle, and as it gets to the anterior aspect of the mandibular floor, it goes through the mylohyoid muscle and innervates what? Anterior belly of the digastric. Okay? Yes.
I know we've covered this before, but where are the SVE components coming from?
Where are they coming from?
Yeah.
They are coming from the main mandibular trunk, and they're being carried until the inferior alveolar nerve enters into the mandible. They're being carried in that trunk. When it gives off the mylohyoid, that branch will take those SVE fibers along with GSA fibers down into the floor of the mouth, okay? Usually below the mucosa, okay?
Are they coming from a certain ganglion or they're just part of the
Okay, let's talk about that.
Yes, please.
What kind of a ganglion are we talking about? Are we talking about an autonomic ganglion? Or are we talking about a sensory ganglion?
It'd be autonomic, right?
Wrong. Okay. What large sensory ganglion does the trigeminal nerve have that has the first order cells for general sensation? Just like a dorsal root ganglion. What are those cells, where are those cells located? In what ganglion? Okay, the trigeminal ganglion that's sitting in the trigeminal cave just below the sella turcica in the sphenoid bone. Okay? That's where all the general sensory cells of the trigeminal nerve have their cell body. Remember, general sensory cells are what we call pseudo-unipolar. They have from the receptor a process called a peripheral process, and that joins the cell body in the ganglion. And then from that ganglion, those processes go back to the brainstem to go to a nucleus in the brainstem, and that's called the central process. Okay, and that's the same for every general sensory nerve in the body. There is a cell body and a sensory ganglion in relationship to spinal nerves, those that are called the dorsal or posterior root ganglion. This is a similar type of ganglion. Only general sensory cells. What are the four autonomic nerves what are the four autonomic cranial nerves?
3, 5, 7, 9.
3, 7, 9, and 10. Okay, 3, 7, 9, and 10. Ocular motor, facial, glossopharyngeal, and vagus. Okay. Trigeminal, for the most part, is the primary sensory feedback nerve in the head. Okay? But it does innervate some skeletal muscles from the perspective of muscles of mastication, the mylohyoid, the anterior digastric, okay, the tensor palatini muscle, okay, and the tensor tympani muscle. Where do all those muscles develop from? First branchial arch. Okay. First branchial arch. Okay. So that mylohyoid nerve coming down here, let's look at how they are entering into this region. Look down into the region that they are entering in. This area here, here's the mandible. Here's the inferior alveolar canal. What's this muscle? It's labeled, by the way, just in case you're having trouble identifying it. What's this muscle? Masseter, right? Okay, what's this muscle? Medial pterygoid. What's this muscle? Vaccinator, okay, what's this muscle? That joins it and forms this union here, called a pterygomandibular raphe. What's that muscle back in the pharynx called? Superior pharyngeal constrictor, okay? That's why they had come up with this term buccopharyngeal curtain, okay? Okay, so what are we gonna call this space that is between the medial pterygoid and the mandible? What do we call that space? That's the pterygomandibular space, or sometimes referred to as a fossa. Okay? Pterygomandibular space. So what's coming into that space from above? The mandibular division of the trigeminal nerve with its inferior alveolar branch, giving off its mylohyoid branch in there. The lingual nerve we'll see is a little bit more towards the midline, towards the tongue, or toward lingually. Okay? So here, okay, here we see this lingual nerve coming down here, okay? Here we see the mylohyoid nerve here. Okay. So this large trunk, I think I might have mislabeled it. I'm sorry, on the previous drawing, this is lingual. And let's do this in a different color. Here is the mylohyoid. Here. Here is the lingual here. Okay. So this is the nerve to the mylohyoid. Over here. Okay. Then we have this nerve here crossing in front of the mandible. What's that nerve? What is that? Crossing in front of the mandibular ramus. And it's going out towards where? Towards the cheek. What is that nerve? Long buccal. Okay. And let's see, anything else? And then inferior alveolar, let's just get that in this color. Inferior alveolar is going into the mandibular foramen here. Okay, so that's inferior alveolar. What's the only division of the trigeminal nerve that has more than sensory innervation? The mandibular division has motor innervation that is associated with muscles that develop from pharyngeal arches that makes them special, and so they are special visceral efferent entities. Okay. Only two components are part of the trigeminal nerve: general sensory and special visceral efferent, only with the mandibular division. Ophthalmic is all GSA. Maxillary is all GSA. Mandibular is GSA and SVE. It doesn't matter that maxillary can carry these GVE components of the facial nerve, and the mandibular lingual branch can carry these parasympathetic GVE components of the facial nerve. Those are from the facial nerve. They are not components of the trigeminal nerve, even though they are carried by trigeminal nerve branches. Okay, so let's look at, okay, so we're going to administer an inferior alveolar block, okay? Now, this on this side is pretty good, okay? So typically what we do is the syringe, let me use black here. The syringe for an inferior alveolar block is coming in from the premolars on the opposite side of the area that you are wanting to anesthetize. So in this case, this is the left side, this is the right side. We're giving a right inferior alveolar block. This structure here is referred to as the pterygomandibular raphe. What is that between what two muscles? Buccinator and superior pharyngeal constrictor. Now when we take whether our index finger, depends if you're right or left-handed, index finger or your thumb, and you put some tension outward on that cheek, mucosa, and skin of the corner of the mouth, you should get the appearance, or what you're trying to do is get the appearance of the pterygomandibular raphe, this fold between buccinator and the superior pharyngeal constrictor. So you want that needle to basically go down to bone on the lateral side of the pterygomandibular raphe. And down to bone is important because bone will stop the needle from going any further. If you're in front of the ramus and you continue pushing the needle through the tissue, eventually, where do you think the needle will come through? One of two places, okay? It's going to go through the parotid gland and then through the skin of the face, or it's going to be in front of the parotid gland and go through the skin of the face. Now, laugh now. This is a real, I mean, we talk about bone being your friend. In this particular injection, bone is certainly your friend because it's going to stop that needle from passing out of the infratemporal fossa and through structures in the face, okay? If you injected local anesthetic into the parotid capsule, what would happen? What would you anesthetize?
Salivation.
Well, salivation of the parotid gland, right? But what else goes through the parotid capsule?
Facial nerve.
The branches of the facial nerve. So what would happen to that patient on that side of their face?
Hemiparalysis.
They would have a hemiparalysis, hemifacial paralysis. Okay? How long do you think that might last with a full carpule of local anesthetic containing 1 in 100,000 epinephrine? 5 to 10 hours. You, out of fear, will be calling your patient every, probably 1 to 2 hours to see if the anesthetic is worn off. okay? That is a negative result, okay? Or, you know, when you inject, if you go through the skin before you inject, the patient will tell you, what's that? I feel like something's dripping down my face, doc. What is that? Okay? And you look there and you see the tip of the needle coming through the face and you say, oh, gee, I don't know. Are you okay? Are you crying? I don't know. You should be crying, not the patient. All right. So, if we look on this mandible here, if we were going to do a inferior alveolar injection, I know. We would come typically between the two premolars. Now these two premolars really are somewhat, have a little bit of an orthodontic problem. Okay, a little bit of anterior crowding here. But we would aim back here, looking for that pterygomandibular raphe, which would probably be coming in about right here. And we would go, usually here's my thumb here for this injection, okay, where it's going to be my index finger, coming up and splitting the thickness of my thumb and taking the needle down the bone. That's as far as it can go. Then I'm going to keep the needle there, rotate the syringe so that it is parallel with the dentition on the opposite side, and slowly inject and pull back or aspirate, inject and aspirate until the needle, in this case, if you see this, it's probably about 50% through the mucosa tissue. Depending upon the thickness of their cheek, it may be all the way to the hub of the needle, okay? So you're injecting and aspirating, you're injecting and aspirating. Now, what do you think is going to be the first branch of the mandibular division that I'm going to hit here? The lingual. Lingual anesthesia is easy, okay? Once you go through and inject, you're going to get the lingual nerve. But the problem is trying to keep this needle above the lingula over here, and that's the purpose of your finger, once again, not injecting into it, okay? And keeping that needle parallel and down to bone, sliding it back, injecting and aspirating until you get an effect. Now, there are a couple of other types of anesthetic approaches that have been developed over the course of time. Really not too long ago, probably in the mid-70s, mid to late 70s. One was described by Jorgau Gates, an Australian dentist, and one by Akinosi, a European dentist. And they developed techniques to try and get a high mandibular block, okay? And there's armamentaria that you could buy, of course, you know, to make George Gow Gates richer, or Akinosi, although Akinosi doesn't need any armamentaria. So Gow Gates would want you to take a plane that is even with the allotragus line. You know what that is? Have you done any face bows yet? Okay. Parallel with the allotragus line, put this injection high up and have it end at the pterygoid fossa, this pterygoid fossa here associated with the attachment of the inferior belly of the lateral pterygoid. Okay? If you are that high up, you should get every branch of the mandibular division. You should get auriculotemporal, so your ear should be numb. You should get buccal, so your cheek should be numb. You should get inferior alveolar, so your entire mandibular dentition is numb, along with this branch coming out of bone, the mental branch, so your chin should be numb, and your tongue should be numb. Okay? Just that, I won't be too vulgar. I mean, what are you doing? What are you doing? What do you want to do with that local anesthetic? What's the procedure that you want to do? Do you want to take one half of his mandible out? I mean, why do you need that profound a block
in order to get the anesthetic effect that you want to do your procedure. That's what you need to think about, is what are you trying to accomplish? What's the therapeutic result that you want? Okay? You know, you want to take out, you know, from third molar to central incisor, okay, I could guess I could buy that. But how many times are you going to do that in anesthesia in order to do that? Actually, an inferior alveolar injection, maybe with a little lingual anesthesia, is all you need to take out an entire quadrant of mandibular teeth. Okay? Akinosi says, well, here's what we're going to do to get into this high mandibular injection. We're going to take our needle and we're going to slide our needle from the premolar underneath our zygoma parallel to the cervical necks of the maxillary dentition and slide that back once again until it stops at the pterygoid fovea. Okay? At the pterygoid fovea. Just another technique to try and get a high mandibular block. Okay? Once again, why are you doing it? Why are you doing it? Why do you need it? Are you doing it because you said, I'm going to try that? Okay? Unfortunately, sometimes that's what we do around here. Okay? I have, be quiet. So we have a tendency to do things that are over and above what we need to do to deliver the care to the patient. What does that cost us? It probably costs us possibly in creating a situation with the patient where they're more uncomfortable in the chair, and possibly creating for us who are going to go into practice where time is going to be of the essence, we're creating something that's going to take more time to do. Okay? I've been in a situation, I was in a practice, there were 6 dentists in the practice. My colleague had a cardiology resident. She was going to do an endodontic procedure. I think it was on 31, second mandibular right premolar. Couldn't get him done. So, you know, all of us, we're up for the challenge, okay? So he's not getting done. He's very anxious, by the way, okay? But he's a physician. All physicians are very anxious in a dental chair. Okay? They don't care if you're cutting a femur in half. They don't think that's a big deal. But sitting in a dental chair is like, life or death situation. All right. So what happens here? He can't get anesthetized, okay? She calls another one of the 6 of us over to try and get him up. All 6 of us injected using techniques that we thought, Akinosi, Gaugates. Not one of us was able to get him to have profound enough anesthesia to do or to start a root canal on tooth number 31, okay? So what I wound up doing is, there's an oral surgeon in the building. We asked the oral surgeon if he would sedate the patient while he's undergoing the root canal procedure, at least the beginning of the root canal procedure, and that was successful. But you're going to have patients like that. They don't get numb. They don't get numb. Or the anesthetic lasts all day. And they'll call you 5 hours afterwards and say, why am I still numb, doctor? So there are things that happen that are things that you don't necessarily expect. If you know what you're doing, you know what to expect. If you get some other type of result, for example, I've had dentists tell me, he said, why did the upper eyelid of the patient droop and their pupil constrict? Okay? Why do you think that happened? Because they went too far back in the pterygopalatine fossa. They went behind the parotid gland or into the parotid gland and injected on the outside of the internal carotid artery. What's on the outside of the internal carotid artery? What nerves? Carotid plexus. What kind of a plexus is that? It is a autonomic sympathetic plexus, innervating structures such as the levator palpebrae superioris and the dilators of the pupil of the eye. Okay? So obviously he missed that lecture, because he had no idea why that was happening. Okay? But now you got a situation, this patient shouldn't drive home because his upper eyelid is drooping, his pupil is constricted, so he's not getting adequate light back in there to see. So you have to know this stuff, okay? You know, I know anatomy, this has been somewhat of a scary course to most of you, but it's definitely something you should be taking seriously, because you will use it every day of your professional life, if for no other reason to administer local anesthesia. All right. But see, now you know that, so if I ask you a question like that on the exam, there's no problem. There should be absolutely no problem, right? Okay. All right, so let's look at this. Here is, now the lingual nerve comes in here. Where does the lingual nerve run in relationship to the mandibular third molar? Where does it run? When it comes out of the infratemporal fossa. Where would we see it? I showed you that in the lab. Where does it run? It runs immediately adjacent to the lingual surface at the cervical neck of the mandibular third molar, right against bone. You're going to extract third molars? You better know that, because a lot of the litigation that takes place in dentistry is in relationship to general practitioners that try to kind of add to their financial situation by doing things that aren't necessarily out of their purview, but out of their expertise. And you go in there with a forceps and you crush the lingual nerve. Or you go in there and you fleck back the lingual gingiva and you cut the lingual nerve. So before you ever take out a third molar, you better make a decision and find out where that lingual nerve is. Okay? So when you go through here, almost immediately when you're traveling back to here, the inferior alveolar injection, you're going to get the lingual nerve almost all the time. If the patient tells you when you start working on the tooth that they are feeling that, don't say to them, well, that's impossible. Okay? Because maybe you just didn't get that needle in the right place to get inferior alveolar anesthesia. But you almost always, if you miss the lingual nerve, I don't know how you do that, but you're going to miss the buccal nerve, because the buccal nerve is out here, and when we go in, we're usually behind the buccal nerve before we administer the anesthesia. So very similar, but we're just going through here to get the lingual nerve over here, just at the distal of the mandibular third molar. If there's no third molar, it's going to be, you know, if there's a second molar, if you're doing some other type of surgical procedure, you just have to think about that. Okay, now we've got this buccal branch. Dentists call it the long buccal nerve. A lot of anatomists in their textbooks only call it the buccal branch of 5. What's the difference between the buccal branch of 5 and the buccal branch of 7?
One sensory, one motor.
Right. Which one's sensory, which one's motor?
Trigeminal sensory.
Right. Trigeminal sensory, facial is motor. Innervating buccinator muscle primarily, possibly a little bit of the upper lip musculature and the lower lip musculature. Okay. All right, so it is crossing the path of the pterygomandibular raphe. Okay? And it is coming out in front of and lateral to this coronoid notch here in the front of the ramus. So sometimes, I mean, now you have to think about this. Am I doing a procedure that's going to involve the buccal mucosa? Do I need buccal mucosal anesthesia? Am I going to place a matrix band and that may irritate the patient's buccal tissues? Or am I just working on the distal occlusal or MOD of a molar tooth or the lingual surface of a tooth? If you don't need it, why give a secondary injection? If you do need it, typically to get the long buccal nerve, you have to inject basically out here. You inject towards the coronoid notch and let the needle go that far and inject the anesthetic. That will get you the buccal branch. Once again, not a lot of anesthetic. Okay. Inferior alveolar nerve has a branch called the mental nerve, okay? Because this is the menton, and the mental foramen is in the menton. And where is it almost always? Where would you see it almost always on a dental radiograph, a periapical radiograph? Okay, the apex of the second mandibular premolar. You will have some of Dr. Syed's questions on this exam. Okay, now, interestingly enough, let's look at this image here. Interestingly enough, here is the mandibular first molar. Here are the premolars. Here's, canine, incisors. When do you think you would specifically go to do an injection into the mental foramen? What teeth would you be working on? Okay, so your anterior dentition, from central incisor back to canine, but also possibly the premolars, first and second premolars, are going to receive some of these branches from the inferior alveolar nerve, which we see here coming into play as it comes into bone and down here and then out mental foramen. Now this mental foramen has a lip of bone on its back curvature, on its posterior curvature. And if you can inject with your, let's see if we can do this once again on the on the skull. Not great mental foramens, but if we come in and we come in from this angle here, from front to back, and go down and aim our syringe needle towards the apex of the second mandibular premolar, the needle will typically, as it's down the bone, it will engage that foramen, okay? If you inject a full bolus of anesthetic there, and then take your finger, your gloved finger, and massage that anesthetic into that opening, you can probably get profound anesthesia for the first molar, the second premolar, the first premolar, the canine, the lateral, and the central. Okay? Without having any lingual anesthesia. Just labial anesthesia. Okay? That's called a mental injection. Okay? That's called a mental injection. Okay? That's a good one to try on the cadaver tomorrow. Okay? That's this injection. because it's a kinder injection to the patient, because you're not gonna anesthetize their tongue. I mean, yes, the lips are gonna play a role in their ability to articulate speech, but not as much as the tongue is going to, okay? They'll be able to feel their tongue won't feel like a large rubber ball. If you inject a large amount of anesthetic, a half a carpule to a full carpule into the metal foramen. Okay, lingual of the dentition, I mean, we can go in here and get the lingual nerve branches on the mucosal side of the mandibular incisors. Remember, only use the amount of anesthesia that you need to do the procedure you're going to do. You know, loading the patient up with anesthetic. You ever seen the movie 10? Ever see the movie 10? The guy comes out of there because the woman that he is stalking, okay, goes to this dentist. So he goes to this dentist, you know, and he just sits in a chair and he wants to be there longer because she works for this dentist. She's a dental assistant, okay. So dentist says, well, you're numb yet? He said, no, give me more. Give me more. You know, give me more. He walks out of there and he's like, he's loaded with local anesthetic just because he's trying to enhance his love life, you know. We do foolish things with ourselves, you know. Okay, so tongue's numb, floor of the mouth's numb. Is the tooth numb? Probably not, okay. Okay, so this here, what we see in here, we see this lingual frenum. What's that frenum caused by? What's that fold caused by?
The attachment of his tongue to the floor of the mouth.
Does the tongue attach to the floor of the mouth? Where's the tongue attached? Doesn't the frenum attach? Doesn't the genioglossus muscle on each side attach to the superior genial tubercle? Is that the floor of the mouth or is that the mandible? Okay, so the fold is caused by the genioglossus.
Can you switch back to the
Yeah, I will. I'm sorry. It's caused by the genioglossus on each side of the frenum, here and over here, okay? And that is a separation between those muscles that creates a fold of this mucosal tissue underneath the tongue. You see the same thing with, up on top, the labial frenum is created by bilaterally the levator of the upper lip, okay? Levator labii superioris aliquinesi on each side. Sometimes there's a muscle in between that's described called levator septi, okay? But the levator labii superioris is causing that labial frenum. You can cut the frenum all you want. Are you going to release? Usually it's done with a theory that this is going to cause a reduction in the tongue being tighter to the mandible. No. You're going to have to cut the muscles and reattach them, resuture them. You're going to have to cut the levator labii superioris on each side to release the tension between the teeth that supposedly is causing this diastema. So the frenum, cutting the frenum does very little, if anything at all. Okay. And then here we've got this sublingual fold on each side coming in here, this little bump. What are those little bumps called? It's got an interesting name. What are those little bumps? They have an opening in them. A little opening in them. You ever go in front of a mirror and lift your tongue up all of a sudden and squirt saliva on the mirror? Okay? What are those openings? Those are the openings of the submandibular duct. Those little bumps are called caruncles. Caruncles. Isn't this kind of neat terminology? Have you looked at their caruncles lately? Okay. So those folds that you see are the submandibular ducts coming there. What is passing under the submandibular duct? From back to front, what is passing under the submandibular duct? Lingual nerve. Okay. Okay. Remember, it's more superior and lateral posteriorly, it's more inferior and medial anteriorly as it goes into the anterior 2/3 of the tongue. Okay, so tomorrow we're going to have a lot of fun in the lab, hopefully safe fun. Yes.
How do we know what group we're in? Is it like A to F?
Didn't I send that out?
No.
I didn't?
No.
Oh, yes, I did, but maybe I didn't. Okay, I'll send it out. I'll send it out.